Okay, I think good. There is one screen is there, so I think everyone will see. Uh, Firstly, congratulations to Sir H. Reliance Foundation Hospital for organizing such a beautiful CME on golden hour. And it's my pleasure to come here. I thank to Dr. Pandit, Dr. Namita, Dr. Chetan, and entire H. Reliance Foundation Hospital team for hosting me here and hosting this pre-conference workshop on acute care medicine, where we will be discussing on acute care aspects of various clinical ailments. So today, when I saw the schedule, I made one presentation, but I saw the schedule. The schedule was that I had 30 minutes. Generally in conferences they give 20 minutes and here 30 minutes. So I thought I should be talking like a master's class on septicemic shock management. So I'll be talking a little bit detail here, but it's very important and it's a very much time-bound emergency. When we go to the statistics in Indian ICUs, one study shows that there is mortality of 66% in septicemic shock patients. Okay, as compared to STEMI, as compared to acute stroke, the mortality is quite high. But sensitivity to a septicemic shock is not as high as we do with the ST segment elevation myocardial infarction or stroke. So it's very essential to emphasize a time-bound care in septicemic shock, and early intervention in emergency department will decide one of the outcomes: either patient will survive, or patient will have prolonged ICU stay, or patient will die. So these things. So emergency department is not just first point of contact; it's the most decisive point of contact in modern healthcare. Okay. So what today I'll be discussing. So today we'll be discussing basic pathophysiology here because it's very important, because septicemic shock pathophysiology is very important. Unless we understand that, we will not able to deal, or we will not able to intervene properly, or we will not able to resuscitate properly unless we understand how things go wrong in septicemic shock. So here I will be talking about the most recent evidence. All of you are you read the surviving sepsis guidance. I will be talking on that. Some insights which we have learned in septicemic shock management over the years, that I will also will share, and the class format will be the mechanism, science, and management. Okay, the 5 bedside things we have to learn and understand. First is recognize before BP fall, give antimicrobial fast, because every 1 hour delay in antimicrobials, antibiotics will increase mortality by 10%. Restore preload and vascular tone. We have to give adequate fluid, and vascular tone is important because in septicemic shock patient goes in vasoplegia, means peripheral vascular plegia will be there and peripheral vascular dilatation will be there. So warm shock phase will be there. So we have to deal that vasoplegia by starting early inotropic supports. Then control the source. Of course, unless we control the source and we address that thing, will not giving the full proof system, and reassess the tissue and not just the treatment. So we have to deal in 3 ways. Okay. So high yield message is that infection triggers vascular failure, microcirculatory collapse, and cellular dysfunction. So our management should be aimed to these 3 things. So I think slides are visible. Yeah. So this syndrome, why this syndrome particular matters? What is the current definition of septicemic shock? If you require inotropic support to keep MAP more than 65 mmHg, and if lactate is more than 2 in that case, that is called as septicemic shock. So that we have to understand. Okay, and it's a life-threatening thing, and it's due to the dysregulated immune response of the body. So when we go for the surviving sepsis guidelines, what is there in this? There are 129 statements and 46 new recommendations. So what all these things say? Just say in, I will do a simple bedside translation of that. 129 statements and 46 new update is that think of septicemic shock as three failures happening. One as infection trigger, any infection, pneumonia, pyelonephritis, a urinary tract infection, that trigger we have to identify. Then vascular or microcirculatory failure, because vasculoplegia is there, glycocalyceal damage will cause this, capillary leak, that will be there. And cellular energy failure means it's difficult to deliver oxygen at cellular level. That's why lactate rate increases. So these things we have to understand, and our treatment should be targeted to all these things. Okay. So important thing. This slide is very important. Huh? Everyone. One is PAMP. What is my PAMP? PAM. Pathogen activated molecular patterns. This is very important. Understand. If you write down and read on this thing, this is very important. Pathogen activated molecular patterns. What that patterns they do? That patterns means whenever there is any infection happens, that will activate pathogen activated molecular patterns, and that will lead to the immune system activation. That will lead to tumor necrosis factor alpha, interleukin 1, interleukin 6, complement, leukocyte activation, and that will, and all these things will make a damage to the tissue, damage to cellular tissue, and that damage will, what will do that? Damage activated molecular patterns. So that will again aggravate this immunological response. So this vicious circle will happen and patient rapidly deteriorates. Okay, so first pathogen activates the molecular pattern, then tissue damage happen, the damage associated molecular pattern will happen, and there will be the aggravated immune response. What that will do, that immune response will do the endothelial failure. Glycocalyceal shedding, vasoplegia is loss of peripheral vascular tone, capillary leak, and due to the endothelial damage, whenever there are endothelial damage, it will cause a microthrombi, and patient will go into the DIC. Okay. Then cellular dysfunction. Yes, patient is means oxygen will not get delivered properly to the oxygen level. What will happen if due to all these things, microcirculatory damage and cycloplegia, vascular shunts will happen. So in some tissues will perfuse more, and some tissues will perfuse less. So even if you see BP is normal, but lactate is 5. Why that lactate is 5? Because microvascular shunts are happen. So due to that thing, due to cycloplegia, blood is moving on one side more of the tissue, and one side of tissue is got deprived from the oxygen, and that will give rise to the lactate. So this concept, that is called as cryptic shock, and that concept we have to understand, because we can say BP to uska normal hai, but lactate is 5. Yes, because BP normal hai, but tissue level is not getting perfused. That is unevenly getting perfused, so we have to manage that particular patient aggressively. And that particularly finally leads to multi-organ dysfunction, shock, ARDS, similar pathophysiology. Okay. Are you with me? The DAMP, immune system activation, glycocalyceal damage, microthrombi. Okay. So this and how the concept of cryptic shock, do you understand? That is very important, because due to this cycloplegia and due to endothelial damage, some means there will uneven distribution of the blood. So shunts will happen. So one part of tissue will not get perfused, but other will hyperperfuse. So that hyperperfuse, there lactate will increase. So we'll see that initial stage that lactate is high, but BP is normal. So we say that a machine may problem hoga. That is not a problem in machine. That is a problem in patient. So we have to be very aggressive while dealing such cryptic shock patients. Okay. So I think that particular thing I have explained in our previous slide itself, and this patient may look stable and lactate is high. That patient we have to be very much cautiously, and we have to treat them equally aggressive. And if patient of BP of suppose 120 lactate is 6, you do resuscitation and see the lactate rate. If it is reduced, then you know that this patient is getting response to your treatment. So lactate is a new vital parameter while doing in emergency department. In our department, I think last 10 years we keep that BP pulse, oxygen saturation, and lactate also. So that gives that not only help us to giving idea about tissue perfusion, but that will help us to prognosticate patient also. So that lactate is very important in all cases. Means we have done one study. So high lactate is associated with high mortality irrespective of underlying cause. Maybe it's a trauma, maybe a sepsis, maybe it may be a congestive cardiac failure, maybe it may be acute myocardial infarction, maybe septicemic shock. High lactate is associated with high mortality. Now, clinical signs and symptoms. Sometimes we say that carry patient to septicemic shock, but there is no history of fever. What happens? The cytokine reset the hypothalamic temperature. So temperature center. So that will what will happen in that situation? That patient will not get fever, and patient will be the hypothermic, even hypothermic. So that is more dangerous. That gives explanation of hypothermia in septicemic shock. Tachycardia, yes, it's a response because peripheral loss of peripheral vascular tone is there. So to compensate that, tachycardia will be there. Tachypnea to compensate the metabolic acidosis. Warm, initially the shock will be warm because peripheral vasodilation will be there. Then patient will go into the septic cardiomyopathy, and then it becomes a cold shock. And altermentation due to low perfusion and due to septicemic shock, encephalopathy. And there will be oliguria and motley. Okay. So lactate, again I am taking lactate, it matters because lactate guided resuscitation is the key in new guidance also, and we have observed in our clinical practice also. So practical target range, you can see that 1.5 to 1.5, 0.5 to 1.5 is normal. Historically, more than 4 is considered as something dangerous, and that should be concerning. So any patient with more than lactate 4, we have to aggressively find out the cause, which is what is behind that. And occult and cryptic shock, normal BP and lactate is more than 2. So we have to be careful in this patient. We should be looking at how the patient give response to the initial resuscitation. Why lactate 4 cutoff? Because in earlier guidelines all studies are made lactate more than 4 or more than less. But what is current statement? Septicemic shock, what is current state matters? If you require more inotropic support to keep MAP 65 minutes of mercury and lactate is more than 2, patient is in septicemic shock. So this matters today. Okay. So cryptic shock, everybody got the concept of cryptic shock? Yes. BP is normal but lactate is high. So we should not get deceived by normal BP. And that lactate is increased due to the microvascular shunting which is happened at the tissue level. Because some vessels are hyperperfused, some got shut down, and there the anaerobic pathway will start and lactate will get increased. Okay, everybody is with me? Okay. Now biomarkers. Which biomarkers? CRP best for perfusion. The lactate, again I am telling that lactate is best for perfusion and stress. Yes, it's like vital parameters. Treat lactate as a vital parameter in emergency department. Then CRP will increase in any inflammation. But if we want to be more specific and we want to find out whether it's a bacterial or not, then procalcitonin. If procalcitonin high, the sepsis is due to the bacterial lesion. So it has good role in roll in and roll out. And one more biomarker is rapidly evolving. We are doing a pilot study on that particular thing. Sorry. So we are doing a pilot study on that, the pre-sepsin. Okay, pre-sepsin means it rages within 2 hours and it's very specific to the bacteria, and it can be a very useful tool in emergency department, though it doesn't came into the standard recommendation. But we are doing a pilot study of a couple of our forces hospitals, and data is quite ensuring, and I'm seeing in next surveillance sepsis guidance, the pre-sepsin will be the ideal biomarker for emergency medicine doctors while resuscitating the septicemic shock patient or while evaluating the septicemic shock. That may come on, and this is another homework, and go and read all about the pre-sepsis. And it's just available in India, and pilot is going on in this thing. So, but it is very promising. thing to diagnose and risk stratify as well as to prognosticate patient. High pre-sepsis, more infection, and it is more specific about bacterial thing, and it rises within 2 hours. Procalcitonin may take 12 to 24 hours, but it start rising within 2 hours of the infection. So it's a very sensitive and specific. So in emergency department workup, what workup should have? 2 blood cultures. Why 2 blood cultures? Why 2 blood cultures? What? Why 2 blood cultures? So yes, you will get 2 blood cultures. So generally, how much? Means 30 to 40% blood cultures only come positive. So if you get 2 chances of, means you will get more. Another thing is that one pragmatic point is that if one sample get contaminated, so you will get something different microbe, but other means that will help to means the contamination should not happen. But a microbiologist perspective, that is very important. Unusual pathogen grow in one set, so he will say it's a contaminated sample. So and that will change entire thing. So 2 blood cultures are very much essential from 2 other sides. Otherwise 2 blood culture लेने के लिए बोला एक ही साइड से 2 blood culture, that should not happen. It should be taken from the two sides. Okay, and then urine, sputum, and if any wound or abscess is there, then that culture should happen. Then imaging, we have to find a patient is in septicemic shock. There should be some underlying focus. Okay, so we have to find out that focus. Unless we get the focus, then we will not do. Suppose the patient having some liver abscess, so we have to rent that. Or sometimes we have seen means very different when we find out pyometra means uterus filled with pus bag. Like that, you have to find out if patient in septicemic shock. Unless and until you don't get a septicemic focus, you should not get settled. So you have to scan patient and you have to find out the reason for that thing. Then lactate, I talked a lot about lactate. In blood gas analysis will give idea about the metabolic status of the patient. Capillary refill, they have emphasized on capillary refill. Don't go by everybody by the blood test. Capillary refill is equally important. Surviving sepsis guidance has given lots of emphasis by capillary refill time, checking the capillary refill time while resuscitating the patient. Then complete blood count, platelets, complete metabolic panel, creatinine, LFTs, PT, INR, equity. Why fibrinogen? Why fibrinogen? Because I have told endothelial damage, glycocaline disruption, microthrombi that will absorb the coagulation parameters and patient going DIC. So that's why PT, APTT and fibrinogen level is very important. And in selected cases we can go for troponin and BBA. Okay. So far everyone is with me. So we have discussed the pathophysiology, why, we have discussed why the concept of cryptic shock, why lactate raises, and what is the triggers for the septicemic shock. Pathogen, activated molecular patterns that will make a damage to the tissue, and then again that will have damage associated molecular pattern, and they go in rapidly in vicious circle and patient spiral down into the septicemic shock. Okay. So first hour in emergency department, what must happen? What should be happening in first hour in emergency department? First, recognize a patient in a septicemic shock. The emergency physician should be able to recognize the suspicion of infection, organ dysfunction, lactate. The lactate will tell you about the organ dysfunction or hypoperfusion, and then it's a medical emergency. Then we have to take the IV fluids, check the lactate, take the blood culture, and then we should be starting IV fluids. And after blood culture, we should be giving the broad spectrum antibiotic, empiric antibiotic, start IV fluid, plan source control, and start norepinephrine. Okay, norepinephrine, when we are giving fluid, simultaneously you are giving 500 ml fluid, you are giving, so that time you are giving norepinephrine to deal with the cyclophagia. Okay, so in new guidance they are saying that while doing the fluid resuscitation, no, don't wait that with some 3 hours you have given optimal fluid resuscitation, and then you are thinking for vasopressor. Here you have to go for early vasopressor, suppose, because you have to deal with the cyclophagia. Okay. So antimicrobial and source control. This is the framework. They have defined 3 things. Septicemic shock within 1 hour. Sepsis is possible, then we should be giving. There are 3 definitions. Sepsis, probable sepsis, possible sepsis, unlikely sepsis. So if sepsis is definite and probable, we should be delivering first dose of antibiotic within 1 hour. And if it is possible, then after evaluation within 3 hours we can do. But if we are strongly suspecting the patient is in a shock and the sepsis is probable, then we should be giving first dose of antibiotic within first 1 hour of arrival. Fluid resuscitation. Thus, initially the last guideline they say that we should be giving fluid 30 ml per kg over first 3 hours. But what they have recommended that we should be doing the personalized resuscitation. Okay, we should be giving bolus. Give 500 ml bolus. Look the patient's fluid status, patient's fluid responsiveness, and based upon that we should be giving the fluids. So you should be checking the injection fraction, looking at the IVC, and then you should be keep on giving fluids gradually, and we can give up to 30 ml per kg. And after that also, if IVC is collapsed, hyperdynamic circulation is there, then you can give further fluid. But that should be the personalized fluid therapy. Okay. What fluid we should be given? The crystallite. They have recommended crystallite, normal saline or ringer lactates. And balanced crystallite, they recommend that will work better. And in certain liver failure cases, we can think for albumin also. Key mistake that it's not rule that every patient should receive 30 ml per kg. If patient's ejection fraction is low, you can't flood that patient. So based upon, we have to, that 30 ml per kg, that should be the standard, but we have to personalize the fluid administration plan for every patient. And then when we are doing this thing, fluid responsiveness, I think people have attended last focus workshop where what we did, we have emphasized on to check the LVOT VTI. That will give us idea about the fluid responsiveness. If LVOT VTI is increased after 500 ml of fluid, suppose. So this patient is fluid responsive, so we can give more fluid. We have given 500 ml and LVOT is the same, that fluid is not fluid responsive. Then we have to deal with other things, cycloplegia and septic cardiomyopathy. So that is very important. So we have to incorporate resuscitative focus skills while resuscitating septicemic shock patient. And of course, low fluid also can damage, and if you give more fluid, that can also damage to the patient. Suppose a patient coming from other hospital, he has received critical fluid and you have seen IVC is dilated. So whether to give fluid or not, that will be discussed, or that decision will be taken on the Vexus. Okay, so based upon Vexus, we can take whether fluid should be given, fluid should be avoided, or fluid should be removed. That is also important thing. So that skill, emergency medicine doctor, we should again, and learning curve is very long. I think some of your colleagues were there. I think within 3 days we have given hands-on training for everyone for LUT, VTI, Vexus, and TAPSE, MAPSE, in all these things. So I think emergency medicine has evolved to a resuscitation specialty, but we have to do the resuscitation with precision, and that precision will be bring by point of care ultrasound and point of care testing, and judiciously using these two elements in emergency department. So vasopressor, first line vasopressor, norepinephrine, route peripherally, because don't wait for central line. We can start this noradrenaline from peripheral line, and it helps especially in vasoplegia, dilated vessels. Okay. And then target should be MAP. MAP should be more than 65 millimeters of mercury, but that should not be last target. Again, we have to do the serial lactate, and we should make that tissue eating purpose. Lactate should get followed. Okay. Now, adjunct. So there are lots of adjuncts. Means in 2016 they removed steroids. Again they brought steroids. Like they are like a Bollywood fashion. Some bell bottom, narrow bottom, fill bell bottom. So sometimes they removed in 2016. They showed hydrocortisone is not there. Now hydrocortisone came back. If IV hydrocortisone when vasopressor requirement persistent despite adequate fluid and inotropic support, if hypotension is there, then we can use hydrocortisone. So that is a recommendation. Yes, low tidal volume ventilation they recommend. Glucose, there should not be tight glycemic control. Initially it was considered a tight glycemic control. Sugar should be between 140 to 180. No, it should be, we start insulin only when patient's glucose go above 180. Renal replacement therapy, dialysis and CRR. So that decision will be taken. Dialysis indication, you know, AEIOU. Who will say that? What is AEIOU? Acidosis? Huh? Huh? Hyperkalemia, acidosis, okay, fluid overload, okay, and the CRRT patient is hemodynamically unstable, refractory acidosis, lactate is more than 10 to 12, anuria, rising creat, in that thing in hemodynamically unstable, CRRT, and hemodynamically unstable, we can go for hemodialysis. So that decision should happen based upon patient's physiology. Bicarbonate is not bicarbonate is what is we should not be giving routinely. So after optimal resuscitation, if required, and if patient is in acute renal failure, in that condition we should be using. And then VT prophylaxis should be there. Enteral nutrition within 72 hours, because nutrition is a very important component. What guide? Genuinely new. So that is a new thing, because that recommendation came this thing. What is genuinely new? That we should be maintaining sepsis dashboard. At what time patient came to ER, at what time first dose of antibiotic happened, how much fluid you have given, and what is the outcome of the patient, and the monthly review of the data. So that is a new recommendation that we have been doing since last 3-4 years. But that is that officially came from the surviving sepsis guidance. Antibiotic timing initially up to 3 hours, no, but in septicemic shock, first dose should happen within 1 hour. Okay. And then initially they thought that give all cover, means antifungal also, no. We should be giving the first dose of antibiotic with local, understanding the local microbial pattern and antibiotic stewardship program of particular hospital, and that good, and then further we can escalate. Not that rifle approach is not good. Some 3-4 pellets will go and one of that will hit. So we have to be that pistol approach, means only single bullet. Okay. So peripheral pressures, age adjusted map. Yes, peripheral means initially give adequate fluid and then look for inotropic support. No. While giving the fluid, you should be giving the vasopressors, because that will help to deal with the vasoplegia. Right? Post-resuscitation fluid strategy, if you think that fluid is overload is there, then you have to remove that fluid. Okay. So, if patient is fluid overload, then so you have to dialyze and remove that fluid. So we can't go with this thing. So fluid overload sometimes sometimes 30 ml per kg, 3 liters, 4 liters, we have given the patient will go in fluid hour and he will not able to get ventilated optimally. So if excessive fluid is there, remove that. And there is called as terminology called as fluid overload nephropathy. There's a low pre-renal low volume will damage the kidney. Post-renal means when you give fluid overload, that will also damage the kidney. So that important concept is there. No value. They have removed vitamin C. No value. IVIG. This is very trendy. That IVIG. That is not that we should not be using. The filters, cytokine, because cytokine storm happen. You know that pathogen activated molecular patterns, damage activated molecular pattern that will lead to interleukin 6, stimulatory factors. So that cytokines. And there they use the cytokine filters to remove that thing, hoping that will reduce the further damage. But now they told that there is no mortality benefit with this thing. So rather than doing that thing, we should be doing the source control more and choosing the appropriate antibiotics. Okay. Now common pitfall, reassured by normal BP. Lactate, suppose lactate is 5 but BP is normal, कुछ नहीं है, machine का problem. Don't get reassured with normal BP. This is the important thing. Waiting for perfect culture. if you are not getting culture, you are getting culture, don't delay. In septicemic shock patient, if culture is taking time more than 1 hour, don't wait for that, give antibiotic first. But you should be optimally take a blood culture and give these things. Equating high lactate with hypoxia. This is very deceptive because we use lactate for prognosticating the patient. But suppose a patient with liver acute hepatitis or acute hepatic failure, उसका lactate 20 आराम से रह सकता है because lactate mechanism where it happens. It's a liver, means whatever this thing. So liver damage will be deceptively very high, but that will not correlate its outcome. So we have to think that lactate will not reflect the lactate of septicemic shock. That is due to the liver. That is due to the damage to the liver, and that high lactate will not correlate with the hypoxia. And same possible in this patient who comes to emergency department with seizure. That may have high, and somebody who are on very high metmorphine dose, the 1 gram, 2 gram per day, like that, they may have some lactic acidosis. Don't give blindly 30 ml per kg. Treating MAP 65 काम नहीं हुआ. You have to go. MAP one goal achieved, but our target is that lactate should come down. Okay. And don't over-interpret the novel biomarkers. Actively, lactate is there, everything is there, but they are all adjunct. We have to see the patient, and based upon the patient's condition, we have to take certain decisions. So bedside algorithm: suspect sepsis, organ dysfunction, lactate elevation, start resuscitation, oxygen, blood culture, first dose of antibiotic, IV fluids, restore perfusion, and reassess dynamically. While giving the fluid, we have to look at for the point of resuscitative point of care ultrasound, and we have to escalate intelligently. So what we have done new beyond surviving sepsis guidance in last 3 to 4 years. In 2003, we saw some septicemic shock mortality around 35%. When we did two new things in our department. Resuscitative focus. While giving fluid, focus guided fluid resuscitation, an individual fluid plan. Look for the IVC, look for the ejection fraction, and based upon that thing, we should giving the fluid. You should be using the LVOT VTI while resuscitation. The first thing. Then early arterial line. This makes your stress less. A patient with 80 systolic comes to you, put arterial line, and based upon that thing, that will give you a real-time blood pressure. So you can give fluid and you can see the BP is rising. Sometimes if patient's BP is falling, you can actively intervene. So that arterial line in emergency department will make wonder. I am sure you start doing it, will reduce your stress and it will improve patient outcome also. So that is very important. So unnecessarily sometimes you may not get BP and sister will not check BP every half an hour. It is continuously these things. Or any pattern suddenly drop or suddenly raise. You can titrate the inotropic support, and that gives a real-time idea about the blood pressure, and you can see the real-time reversal of the disease process. BP 80 and it is happening 128. It will give you satisfaction while resuscitating the patient. And it will again reduce your stress, and against patient, we are all hardcore emergency medicine doctors. We are resuscitants. Any patient who responds to our resuscitation gives us a rewarding experience. So that real-time rewarding experience will get there. Precision resuscitation means focus and real-time hemodynamic. That two things that we have done, and our mortality from 30 to 40% we have reduced to 20% in 2024. And that case, that data we have published, we have presented in 10th International Conference of Quality Summit, and we have won the first prize in that. We have won the Clinical Excellence Award in the 10th IHH Quality Summit at Hong Kong in that particular disease. So it rewards and patient outcome. When we do the resuscitation, our patient gets saved. That is a reward. But when we genuinely resuscitate the patient, and if we keep the data of what we are doing, what will happen? Even system also recognize. System means universe will recognize you are this thing, and that will also rewards. So I think this is the first big international award. I think I got through the septicemic shock. So this particular topic is very close to my heart, and septicemic shock is very important, and we should be dealing it with very aggressive resuscitation with precision is the key. So finally, I'll people may know me. I will be talking about MCON a lot, but yes, I have to talk because organizing chairman, you don't know, it's like a daughter's marriage, 10 daughters marriage at a time. So nowadays there is a problem with son's daughter also. So I can say this. sons, 5 sons and 5 daughters marriage I am doing at a time in one day. So this particular conference, it's India's first international conference in emergency medicine. We got registration from every continent of the globe. Royal College of President of Royal College of Emergency Medicine, you must have seen, he has given the video message and he personally coming. President of American College of Emergency Physician, he is personally coming, he has also given a video message. President of International Federation of Emergency Medicine, she also coming this thing. And importantly, President of WinFocus, recently I shared the video. WinFocus is the apex body of point of care ultrasound on this planet. The president of that WinFocus is also coming here. She has given the video message and she will be giving the keynote address. So this has evolved to an international conference. I can say this is India's first international conference on emergency medicine, and I assure you it will be the unprecedented event. And those who are not registered, please register. Be the part of the movement that will define future of emergency medicine in India. The concept of this particular conference is innovation, collaboration and excellence in emergency medicine. And I again say that excellence in emergency medicine begins with excellence in resuscitation. Many say that who are we masters of? We are masters of resuscitation. Thank you.